So, I'm going to tell you 3 stories now. And these stories will basically frame the health and healthcare system as it relates to information technology, but more as it relates to information. Okay? And why information? I don't really care about technology. Technology is the enabler. And let's talk about why. The reason I have an inukshuk there, so in 1992 when I graduated from McGill, my first job was in a place called Salwood. I'm one of the few physicians in Canada to be permanently placed in the nursing station. I was young, scared, didn't know what was going on, but the good thing is there's lots of places to hide your mistakes. Except they don't biodegrade quickly on the tundra. That's a joke. Hopefully I didn't kill too many people. Hopefully I didn't kill too many people. And they're all like, shit. You still work as a clinician half-time. You're more than welcome to come and see me. But I'm based up here now. There's still a lot of muskeg and stuff to throw mistakes into. But so I lived in Salo. It was fascinating working in a nursing station. One day I had this case come in, and this was it. But it's not the real X-ray, but it's representative of it. It was a little kid who had been dropped on a concrete step. Not intentionally, by mistake. The mother was really upset, 6 weeks old. So 6-week-old kids have sutures. They have cracks in the skull. And why? Because when kids come down the birth canal, their heads mold, so everything works. Now we won't go into the details. And I did an X-ray. So I didn't do the X-ray. The janitor does the X-ray. So in nursing stations in Canada, the janitors largely do that. The janitor later shot a polar bear. It was a woman. So that came into town. It's a cool place to live. It was the only time I saw a polar bear up close was dead. But so there were these 2 lines, like these lines, on the skull. And I'm looking at this. I pull out textbooks trying to figure out what is wrong with this kid. And the kid was alert, had been crying a lot, seemed a little somnolent, tired, and had cephalorhematomas, or goose eggs, on the scalps bleed a lot. And if you've ever sewn up a scalp, they bleed like stink. So I had to figure out whether these 2 lines were skull fractures or just sutures. And the question the question was is if there are fractures, the likelihood of a bleed is increased and of death is significantly increased. If it's just sutures and the kid has a bruise on its scalp, I mean, why medevac someone for $10,000 for a bruise? Right? So that was the question. And so I looked at this and I pondered these, and I couldn't figure it out. And I looked at the book. So finally, I decided, well, I'm gonna use information technology. And here's the question: do I medevac the child for $10,000 or $15,000? Or do I somehow send an image, like a PAC system, which didn't exist? But I decided to send an image. So I drew I traced on a piece of paper the picture, and I faxed it down to the radiologist, and it was a really shitty drawing, and they laughed at me. And the irony is everyone in my family is an artist, other than myself. So when you consider this binary, my choices here, you have to consider what's the best way to provide quality of care to this child, right? And quality of care is safe, efficient, effective, equitable, timely, and patient-centered care, as defined by the Institute of Medicine, right? So what happened ultimately for that story is that we put the X-ray on a twin otter. It goes out, comes back 2 weeks later. I kept the kid because I was convinced they were sutures. 2 weeks later came back. The kid lived. It's great. Came back as bilateral skull fractures. So I was wrong, right? Now, most people who fracture the skull don't bleed, but there certainly was a chance, and if I'd known, I probably would have medevaced them. But I was wrong, and there was someone sitting down in Montreal or Ottawa who could have answered that in around 20 seconds. Right? But I didn't have the knowledge. So the knowledge was readily available. So what that tells me is the exchange of information between myself. I wore a dress frequently, and I still do sometimes. So, don't tell my wife. So the exchange of information between myself and some specialist or the patient's information, that exchange of information is deeply important. The value proposition of the digital revolution is information. It is not technology, right? This is useless to me to help someone. What it contains can be very valuable, the information I get. That's a very important principle, right? Okay, and information comes in a variety of forms. We listen to people, we examine them, we talk to specialists. That's what I wanted to do in this case. We talk to family and friends, the sort of circle of care of the providers, of the patients. And we have stored information in all kinds of ways. In charts, we have, the charts are right here. We have lab, DI, clinical decision support tools, and scheduling information. These are all the forms of information we have. We want to develop some sort of relational design of a system that allows us to exchange all those forms of information. That's an optimized healthcare system. Because if there is no information exchange, there is no healthcare. We have an information industry. So everything we will talk about henceforth is based on this. If there is no information exchange in healthcare, there is no healthcare. If I can't talk to a patient, see them, do anything, I can provide, can't read a book, can't look at their chart, can't do anything, I cannot relate to them. I provide no care. Now this seems sort of self-evident, but what's interesting is if you look at the design of the healthcare system, this has largely been ignored.